dialogue. I think it's good to have alternative positions on matters. We need to discuss. This isn't a simple issue. We had plenty of critiques on our work when it came out, and we responded thoroughly as best as we could through public presentations and tried to deal with it as scientifically as we could.
Thank you, Dr.
And I'm all
Hosek.
for debate. Yeah.
Thank you, Mr. Johns. Next, Mr. Genuis, for 5 minutes, please.
Thank you, Chair. My questions will be for Dr. Summers, but I do have a quick comment for Professor Perrin. I want to say, sir, that I respect your sincerity and your conviction, and I've read your book. I do think your comments demonstrate the risk of combining good theology with bad science. I agree with you that love and compassion should define the character of our approach, including love expressed through effective dissuasion from danger and support for recovery. But as Dr. Summers has demonstrated, the NDP Liberal approach to drug policy is wreaking havoc in our communities. It's causing diversion, and it's supported without credible evidence and pushed to the extreme by self-interested industry groups. My first question for Dr. Summers. Many people are hurting as a result of the ongoing and escalating drug crisis, but there are some who benefit from it. Those who produce and sell the products driving this opioid crisis are making money off the suffering of others. And whether they wear hoodies in dark alleys or suits and ties in the halls of power, these drug dealers are benefiting from the pain of the most vulnerable. You've talked about public health officials like Dr. Perry Kendall, who have gone from health policy roles where they advocate for decriminalization and so-called safe supply directly into business selling pharmaceutical-grade hard drugs. Do you think there should be rules in place to prevent former public health officials from going on to financially benefit from their previous positions?
Thank you for the question. Yes, there absolutely should be rules. These types of relationships should be transparent. The Stanford Lancet Commission urged the same thing. In fact, when they assessed the roots of the North American opioid crisis, Canada and the U.S., the first area they highlighted were conflicts of interest and the movement. And Dr. Kendall unfortunately illustrates this, of people who move from roles in senior public health and governance roles into, in his case, the BCCSU, and then also into roles with other organizations like the BC Centre for Disease Control, which has been flagged as a source of funding for the very company that he and Dr. Schechter started. So it's one thing to consider whether the action of moving into pharmaceutical provision of drugs is a sensible thing. It's quite another to be advocating for that and setting oneself up to be the provider. So yes, there should be transparency.
Thank you. You alluded to this. The original cause of the opioid crisis was Purdue Pharma. They advanced drug liberalization in order to aggressively market their own new opioid product, OxyContin, in the 90s and early 2000s. This is how the first opioid crisis began, and certainly there was conflict of interest rampant at that time, people moving back and forth between companies and regulators, et cetera. Now, today, Purdue is at it again. Their own branded hydromorphone product, Dilaudid, seems to be the preferred option for this program of state-subsidized hard drug distribution. It seems bizarre to me that the people responsible for the opioid crisis at Purdue are now making even more money selling drugs, marketing easier access, and drug liberalization, again, as a solution to the problem. Do you have any insight into why a Purdue product specifically has become the go-to, and what Purdue has done to engage government and civil society to be able to bring out this outcome that's very financially beneficial to them?
Unfortunately, no, I don't, but I share your observation that it is a perverse irony.
We know that Fair Price Pharma has met extensively with this government, meeting multiple times with the previous Minister of Mental Health and Addictions in person, and having, I think, 12 meetings over the course of 2 years with officials. Dr. Summers, I have moved a motion at the Government Operations Committee asking for the release of these so-called safe supply contracts. I believe that parliamentarians and the public should know about the kinds of deals that these high-priced companies like Purdue Pharma have signed with the federal government. Liberals have been filibustering that motion of the Government Operations Committee in order to prevent the release of those contracts. They've said on the one hand they don't think any such contracts exist directly between the federal government and these companies, but at the same time they filibustered to prevent the release of those contracts. Do you think those contracts should be released, and why do you think so if you do?
They absolutely should be released because they represent public expenditures that are directly related to a highly, highly controversial set of drug policies that really are only active in Canada. So we absolutely need greater transparency. I would add that we need greater transparency on the flow of public and private funds into organizations like the BCCSU. Our standards for reporting in comparison to the U.S. Sunshine Act are relatively lax. And we need to understand better how our funds flowing through organizations like the BCCSU into community groups that are allied with their advocacy, Vandu, Dolph, and many others, and how are pharmaceutical funds augmenting those monies in order to pursue what appears to be a concerted agenda.
Thank you, Dr. Summers. Next, Dr. Pawlowski, please, for 5 minutes.
I'd like to start off with a question for Professor Summers. You mentioned, and I didn't quite pick it up, but maybe you could tell me again and maybe explain it a bit. You said at some point you were ordered to destroy your database. Who ordered you to destroy the database? Why? And did you actually destroy the database?
We were forced. I did my best to protest. We were forced to destroy the database, and so that has been done. I provided a briefing to deputy ministers, all the non-dirt deputy ministers. The province of British Columbia, the government of British Columbia.
And you, as your database was as a professor at UBC?
I started it at UBC. I subsequently moved it to my position at Simon Fraser University. This is data that we obtained from multiple government ministries, in some cases with the consent of people that we were aiming to assist, people with profound addictions who were living homeless in Vancouver and who were participating in some of our intervention efforts. We had a large raft of information spanning more than 20 years. We had been doing this work for 2 decades, and we received that instruction 1 week after I provided the briefing.
What was the reasoning for that there was confidential information in there you weren't supposed to have, or like why?
No. There was no
rationalization.
There was no question of propriety. In fact, we had agreed with the government to renew the database for another period. That had been formally completed with the Ministry of Health, and we were rebuilding it around an additional study looking at addiction and death in COVID. There was no rationale. The government lied by saying that they were planning to do this anyway, which clearly was not true. If there was, there would certainly have been some prior communication about that. They said things that really didn't make any sense, that we could get the data from other sources, which is clearly false. There is no other way to get these data. The only rationale that makes sense to me, and I've had this confirmed from one of the deputies that was in the room, was that my remarks antagonized some of the deputy ministers because they got the impression that I was saying that their policies addressing addiction and homelessness were not effective.
Well, why did you comply with that? I mean, it seems like an administrative order by someone in government. It wasn't a legal authority. Like, why did you do it?
No one at the university was coming to my defense, and they persisted in ordering it done. I didn't see any recourse. Maybe I should have spoken with you earlier.
Maybe. Okay, Mr. Perrin. You talked about your Christian faith, and I agree with a lot of your positions on harm reduction. What do you say to people who are concerned about somebody smoking crack next to them on the beach when they're there with their kids? What do you say to the little old ladies you're your parents who want to go downtown in Ottawa or BC but are afraid to because of open drug use. People are using drugs, and we've heard with methamphetamines, they sometimes become psychotic. The fact that a lot of downtown cores have become a little bit of a hellholes, and it's revolving around things like safe injection sites. I'm sure, or I would think, that you have some sympathy for these people while still believing in harm reduction. How do you get that balance right? And have we got the balance right?
Yeah, thank you for the question. First of all, we've had public drug use in Canada prior to the now largely rescinded decriminalization pilot in BC and in other cities. As I travel throughout the country, I see the types of things that you're talking about, and it's not limited to BC or Vancouver. In terms of, I want to talk briefly about BC though. The Vancouver Police Department, and this is a quote from Inspector Phil Hurd, who oversees the VPD drug unit, stated on March 3rd, 2024, he said, "We've actually seen a decrease in public complaints around public consumption." And so that's a direct quote from him. When Chief Constable Adam Palmer was asked about any sort of statistics that were kept around the police claims that they didn't have recourse for the types of situations you're talking about, this is a quote from the article I'm referring to, Palmer said the VPD had not kept statistics on the number of incidents where a person was using drugs in a public place where police were unable to intervene. So really, what we're sort of seeing is, quite a large upspring in concern, but the data is not backing it up. So how do we get it right? How do we get it right? Sorry, go ahead. Professor, I can't hear you.
Thank you, Professor Perrin. Thank you, Dr. Pawlowski. Suite, Monsieur Thériault, pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Ms. Jutras, we know that we can't use just one approach. We can't grab everyone off the street and bring them to a detox facility. Harm reduction has an important role to play. Among the people who opened up their hearts to you, is safe supply something that has a positive effect, a stabilizing effect on their attempt to get better or to have a better life? Yes, most assuredly. But once again, this complex problem does not necessarily work completely through that method, but there are some successes. I have testimony from one person who says, "What changed for you? Was it having a safe supply?" The person said, "Well, now I'm fatter," because that person was always looking for substances, so wasn't eating properly anyway. But now they were much healthier. They'd start working again and said, "Now I have a bit of money at the end of the month." So it makes a big difference for the life of that person. So there's stabilization of consumption as well. Yes. Essentially, there's an adjustment too. An adjustment of the substance. You find a balance. Because on the street, you don't always have that balance. You say, "Yes, I'm going to take this dose or that dose," but it can vary. It can be ever-changing, so you don't have the same stability that you do with specialist doctors. It can create stability when it suits the person. Some people talk about diversion of the safe supply. In Abitibi-Témiscamingue, do you find that is true of this approach? A very brief answer, please, Ms. Jutras. Well, not necessarily, because if the person uses the substance because it meets their needs, I don't know too many people who are going to divert that supply. They would be weaned off of it then with some difficulty, so it meets their needs. Thank you very much. Mr. Johns.
Minutes.
So, Mr. Perrin, you are the former senior criminal justice policy advisor for the Conservatives under Prime Minister Stephen Harper. You've heard the Conservatives of today talking about opposition to safe consumption sites, to safer supply, to decriminalization, blaming actually all of the deaths on these policies from the NDP in British Columbia. Can you talk about your concerns about this rhetoric and also what policies you would not recommend to be adopted by the Conservatives and why?
Yeah, I'll be honest. I'm feeling pretty frustrated, to be quite honest, with the distractions that I've been hearing talked about today in the committee. I was checking on social media right now, and one of the committee members is posting already gotcha clips from this committee hearing in the process of the hearing happening. Is this about hearing evidence about how to save lives, or is it about your social media channels? Is it about getting hits, or is it about saving lives? So I'm disgusted by that, actually. I'm disgusted. And the lives that are going to be lost, we know. The opposition to a supervised consumption sites, we know, kills people. And the Federal Special Advisory Committee on the Epidemic of Opioid Overdoses had projections from December of 2023. They projected hundreds more would die if these harm reduction measures were not scaled up across the country, and their forecasts have been proven correct. And this will only worsen if we have a federal conservative government who suppresses, shuts down, fails to fund and support these life-saving medical interventions.
So, go ahead. Sorry.
I was going to say, in terms of policies that I would not recommend that be pursued, to start with, we're being told that our goal should be to bring people home drug-free. And one of my co-panelists talks about how he frequently talks about addictions. He's not talking about actually saving lives. He's repeatedly referred to evidence about addictions, not about saving lives. And we don't have an addiction crisis. We have a toxic, unregulated drug crisis. And so what the research shows, again, is if our focus is on simply detoxing people and getting them off drugs, if that's the main goal, that has an elevated risk of death. When your treatment is all about detox alone, it's not medically recommended. So I would not recommend that kind of treatment and recovery. Secondly, the idea that we can stop fentanyl at the border has backfired. Fentanyl is now being made here in Canada. We know that from the RCMP. Additionally, we've been told, jail not bail. In the context of this crisis, a better slogan would be that jail means death without fail. That's for people with opioid use disorder. When we look at the data, who is dying? In Alberta, former Premier Jason Kenney said that half of every Albertan who died of unregulated drugs had been in custody in Alberta within the last 2 years. In BC, it's 2/3 of all people. So we need to stop locking people up and perpetuating this failed war on drugs that is only making things worse.
Thank you, Professor Perrin. Next, Mr. Doherty, please, for 5 minutes.
Thank you, Mr. Chair. My first comment, it will be a comment, not a question. So there's no need to reply, will be to Mr. Perrin. Actually, I do have a question. Mr. Perrin, do you have a medical degree?
No.
Okay, thank you. And next will be a comment. Not one person is talking from the Conservatives, whether it's our leader or ourselves. Not one of us have said anything about safe consumption sites. In any policy, any conversation, there are many tools in the toolbox. You're conflating the issue with your anger or frustration towards the Conservative team.
So you publicly support supervised consumption sites today? You publicly support them?
I have said that there's many tools in it. With Mr. Perrin, I'll ask the question. Mr. Perrin, I'll ask the questions. Thank you very much. I've been on the record as saying there are many tools in the toolbox. Mr. Summers, Dr. Summers, sorry, you have said, and I appreciate our Dr. Pawlowski asking the questions regarding the database and the destruction of the database, but you've also said that you have there have been activists that have waged war against you in terms of defaming you and discrediting you. Can you elaborate a little bit more on that, please? Paid activists, sorry.
Thank you. Yeah, it started some time ago. We were stymied in gaining access to additional data to link with the databases that we already had. Those were actions by the province and the BC CDC, but it really became most clear when we published the rapid review. And I don't understand Professor Nosik's remark. He clearly is not interested in dialogue. He signed a letter that maligned publicly our work. And the only time I've spoken to him, he told me that he was emotionally angered by it because at the time he had responsibilities to conduct research on safe supply. Almost all of the signatories, all of the signatories of that letter that I know have financial interests in the very topic we were reviewing. We didn't conclude anything that was unusual at the time. It was that there is an absence of evidence. Professor Nosik has even confirmed that today, saying that things were just getting started. So the fact that we pointed out, what we did is point out an awkward thing, which is that the standards for introducing a pharmaceutical in any form of practice in our country and around the world typically follow rigorous assessments of their safety and their effectiveness. And in this case, we decided that we were going to implement a measure without any of the controls that we used for COVID vaccines, looking for positive effects if there are any, harms if there are any. We simply launched into it. And as we now know, the studies that have been produced were fashioned on the fly. There was no traceable component in the drugs that we introduced in order to enable, in a fairly obvious way, the ability to detect diversion if it was occurring. And so we have this not only this odd mashup of evidence today, but more importantly, we clearly adopted a double standard in proceeding with this very experiment. And is that because of the people that we're discussing?
Are there documents that you feel this committee would benefit from being able to read that may support us in going down this path that you suggest that we should petition to try to receive?
Well, there are a few that come to mind immediately. So one is the Safe Supply Review, which we called Public Supply of Addictive Drugs. I think it's premature to be using the word safe in the label. The second is a review that we conducted on decriminalization. It will correct some of the misunderstandings that have even been stated here today. Police chiefs in Canada and in BC both wrote reports on decriminalization stating that they were supportive only if robust measures were put in place to help people that police officers encounter, and that has not been done. A third document I'd recommend is the Stanford Lancet Commission report. And the fourth is the Portuguese National Drug Strategy, which is a document rich in its complexity, in its direction, and illustrates for, I think, other nations how we can get our heads collectively around a concerted approach that isn't referring vaguely to tools in toolboxes and making things hyper-political, but actually integrated and purposeful.
Thank you.
Thank you, Dr. Summers. Can I ask just one question? Those are 4 public documents, I believe. Would you be able to provide the committee with those this week by any chance? Thank you so much.
Happily.
Thank you both. Madame Brière pour 5 minutes, s'il vous plaît.
Ms. Brière, 5 minutes. Thank you, Mr. Chairman. Dr. Summers, do you have any evidence that Fair Price Pharma got some profit out of the safer supply?
Their financial documents, and even though, as we're aware, not-for-profits can still pay people. So I'm not aware of the flow through of funding or their success in obtaining funds in the first place.
Did the BC government propose that you have access to a new database to continue your research?
No, unfortunately, they have not. It's my belief that their intention was to ensure that there was not the capability to assess the performance of the programs that they have grown over these last few years.
Thank you. Dr.
And Dr. Nozick, we all know that the opioid crisis is a complex one that is multifaceted. We also know that one of the challenges for people with an opioid use disorder is long-term retention. When you start treatment through agonists, do you agree that that difficulty in keeping people on this type of treatment is because of stigmatization or lack of options?
I think those are both contributors to the problem. We have a lot of experience with opioid agonist treatment. For a very long time, it's been accepted that, this is a chronic recurrent disease, and that people typically go through stages of remission and relapse. That process has continued, but as people relapse, they're now being faced with a far more toxic illicit drug supply. It's far more dangerous to relapse off of opioid agonist treatment nowadays. And so we need more options to keep people safe. Treatment is one part of a continuum of services that we need. I think we need to adjust our expectations and adjust our knowledge based on the introduction of new contaminants into the drug supply, which is still happening. The ground is still shifting beneath our feet here. So we're trying hard to keep up, and it's painstaking to watch our outcomes continue to deteriorate, and it's painstaking to hear from physicians who are trying their best to keep their patients alive. It's difficult.
Merci.
Thank you. We just got back from a trip in various cities across the country. We met with organizations that work in the field, including Ms. Jutra's organization. She's with us this afternoon. We see people suffering. We see people looking for solutions. Among the people who are working to save lives, as well as the drug users themselves. You're talking about finding options. We who are sitting around this table and who have to find some kind of solution to stop this crisis, what would you recommend?
The question is for you, Dr. Nozick.
I'm sorry. We need to recognize that there is a place for recovery. There is a place for outpatient treatment, and there's definitely a place for harm reduction. All of these need to work together. It's painstaking to see, continuing deteriorated outcomes. I think it's also frustrating to see that, more and more this has become a public discussion of finding culprits and throwing stones rather than finding solutions. I came here to provide my expertise, to provide evidence that I had generated and that I've come across, and I'm hoping that I'm coming across that way as a constructive member of this panel to give you evidence to build on. We need more information. That was the bottom line statement from my introductory speech. We don't know very much of anything about recovery-oriented models of care. We don't know very much of anything about the outcomes of short-term detoxification. That's the sort of thing that needs to be reported systematically across the country.
Thank you, Dr. Nozick.
Thank you.
Next, Ms. Goodridge, please, for 5 minutes.
Thank you. I guess, Mr. Summers, you started out your opening statement referring to the fact that you're in recovery, and I was just wondering if you could share with us a little about that, because I think that probably shapes how you approach your work here.
Honestly, I'm not sure, but you decide. So I was adopted. I grew up and was exposed to traumatic experiences at an early age, and developed mental illness symptoms and addiction symptoms, and those persisted for a number of years, starting around age 9. Left school and was out on my own as an early teen. I was relocated to another family, and I found some beginning stability. Many people, well, when we look at how people identify recovery, it includes several components: connection, hope, an improved sense of identity, motivation for the future, and a feeling of empowerment. Recognizing that one of the core features of addiction is the experience of loss of control over one's behavior while one is aware of the harms that are resulting. And those components spell the acronym CHIME. CHIME has been produced through meta-analyses and systematic reviews. It's been replicated. This is how people describe their experience of recovery, and that was certainly true for me. I was fortunate to find it through study and mountaineering and pouring my energies into those types of activities. I never went to 12-step meetings, but I know many people, of course, who benefit from other methods of transcending their loss of control and finding those qualities that are summarized in the acronym CHIME.
Thank you for sharing that, and I think it's important for people to understand what exactly recovery is and how it can look and play out in different spaces and aspects. I guess my question is, when it comes to Fair Price Pharma and their heroin, do you believe that there should be a move towards a retail heroin business in Canada, as is being purported by Fair Price Pharma?
No, I think that would be a very ill-advised step.
Vending machines, and so the vending machine for so-called safe supply that Dr. Mark Tyndall has put forward, do you think that is a responsible use of taxpayer dollars?
Not at all. The familiar refrain, which has some truth to it, that addictions are problems of loss of connection, it is bewildering to put a vending machine between the government and a person who is suffering, rather than an opportunity to interact with a human that can accompany them on some constructive steps in a healing path.
I heard you a while back at a conference in Calgary talking about the housing market, and one of the studies you did about who were the most successful post-recovery in housing and which housing models were, and I was just wondering if you could expand on that a little bit.
Canada has a major tradition of following deinstitutionalization, along with many other places, the tradition of predicating that closing of large institutions on a commitment to instituting community-based, recovery-oriented services. This is a decades-old refrain that we were reminded of when Senator Kirby crossed the country and summarized his findings in Out of the Shadows at Last. Once again, we were told we have not closed that gap. Canadians funded the world's largest randomized controlled trials evaluating recovery-oriented housing in comparison to usual care. The results were dramatic. I led the trials in Vancouver, where our focus was on addiction. We found dramatic reductions in crime, medical emergencies.
Are there any documents on that?
A large number of...
Could you table those with
publications.
if you could table those with the committee, that would be spectacular. So just to follow up on some of these points, I wonder if perhaps we could get agreement around the room to have the documents produced, specifically financial documents, donor information, and contracts with the government for Fair Price Pharma, MySafe, to add into our committee. So I'm just wondering, Chair, if we could have...
Okay, you're out of time, Ms. Goodrich. That's a request for unanimous consent for the production of some documents. Is everyone clear on what's being asked for? Okay. Do we have unanimous consent to request those documents?
No.
Okay.
Not right now.
There is no unanimous consent.
Mr. Chair?
Do you have a point of order, Mr. Johns?
Yeah. I'm happy if my colleague wants to bring this back at another time and we can revisit it.
Thank you. Okay, Ms. Goodrich. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. Mr. Chair, my first question is to Mr. Perrin about misinformation. Mr. Perrin, my question is about the deliberate political strategy of some post-truth populist politician. We know some post-truth populist politicians south of the border and in our country are spreading misinformation for electoral gains, for fundraising. Do you have any evidence or number to share with this committee on how misinformation impacts the life of Canadians?
Well, that's not an area I specifically study, but I can comment on what I know in the context of this committee's work on this unregulated drug crisis. First off, generally, we know that misinformation spreads more rapidly than truth. And the likewise corrections or responses are also very, very slow in coming, if at all. And so what most concerns me is we see a persistent and repeated pattern of misinformation and lies being spread by the current leader of the official opposition who seeks to become the next leader of our country on this issue. It is deeply repugnant that a public health emergency that is killing tens of thousands of Canadians, that there would be any dispute, let alone deliberate spreading of misinformation about the proximate cause of that. We know from every available source what the cause of the toxic drug crisis is. It is illicit drugs made by organized crime, full stop. Now, there are reasons people take drugs. There are different pathways we could take out sort of policy. But if we can't even agree on the problem, we're never going to get to saving lives. And so I think that is the starting point for this committee's work is, do the members of this committee agree on that's the problem? The second is, what's the objective? Is the objective to save lives, or is it to follow the polls? There is a clear correlation between policies that are not evidence-based, cracking down on people who use drugs, forced treatment, which poll very well, that also result in increased deaths according to the research. I'm sorry, I can't hear you.
So you agree that the misinformation costs lives or impact the health of Canadians?
Misinformation on a pressing public health issue like this absolutely is killing Canadians. It is fomenting opposition to what we know to be life-saving medical interventions, things like supervised consumption sites, which I think is just incredibly disingenuous for one of your colleagues on the committee to claim without being very clear, but saying it's part of a toolbox, whether the Conservative Party supports it or not. If that's the case, I'd like to hear Mr. Poilievre. I challenge Mr. Poilievre to stand up in the House of Commons tomorrow or at a public event and state, I support supervised consumption sites, period. That's a simple sentence. Is that his policy or not? We're not here to play games. The lives are at stake, and Canadians have a right to know.
We see many biased political pages spreading misinformation online. The government of Canada had a similar issue during the pandemic, where we had to use advertising and working with a local journalist to provide accurate information. What approach do you recommend to this committee on combating this type of information, which is called misinformation, when it comes to addictions?
I think there's a role that the media has to play. I think there's a role that politicians have to play. Ultimately, we're in a climate that's unlike any I've experienced before. I remember the days when if you had facts and credible evidence to support a policy, that would persuade people. We're living in a post-truth world. It's very difficult and frustrating for those of us who are concerned about facts and truth. But I think we have to continue. And the people who are most impacted by this need to be at the table. We need to hear from them. And I don't know, I've looked a little bit about the committee's witness list, but I would just really strongly encourage the committee to hear from more people with lived experience whose lives, there are 400,000 Canadians who have gone to supervised consumption sites, over 5,000 Canadians here just in BC who have relied on a regulated alternative to the toxic criminal drug supply. Those are the folks who the committee needs to hear from. And they will give you the evidence that you need to hear.
Next question is to Dr. Nozick on shared jurisdictions such as public safety. This committee had an important testimony from law enforcement agencies in BC about the tools they require from provinces. And we know municipalities are in charge of local bylaws. What recommendation you can give to the committee on working with the provinces like BC and municipalities to respond to this crisis?
I think collaboration across jurisdictions, across different sections of government. It's not just public. This isn't something that the public health sector can solve on its own. We need collaboration with law enforcement. We need collaboration with housing and the ministries of child and family development. This isn't something we can tackle alone in the space of public health.
Thank you, Dr. Nozick. Thank you, Ms. Sidhu. Suite, Mr. Thériault, pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Yes. Ms. Jutras, given the crisis in toxic drugs that kill, we have to be able, and this is a constant we have to be able to be where the people who are addicted are. At the same time, that accompaniment has to be available at the moment they need it. Which approach should we favor in order to help these people more effectively? Well, for sure, we have to listen to them. That would be basic, because every individual doesn't have the same history. They're not at the same point in life. They don't all have the same needs and objectives. So listen to them, consider them as experts of their own situation, and not necessarily attempt put them on a path to a cure. You have to listen to the person. There's a document we use a lot called From Oral to Written. If you organize the margin will organize itself somewhere else. So there's always going to be marginalization, is what I mean. You can't push people into living in a certain type of community. There's always a margin. You can create bridges between that margin and the rest of the community so that there are passageways. I understand that, avoiding to impose a specific approach. Offer them a choice. Okay, I'd like you to discuss another thing. We talked about safe supply, but supervised housing. Isn't that, in terms of harm reduction, one solution? It's not a miracle, but isn't that something that can bring about stabilization and improve quality of life progressively? I think her system is frozen. That's all the time we have anyway. Well, if she comes back, perhaps we'll try to solve the problem. Perhaps we could hear her answer if ever she comes back, with your consent. Thank you.
Passer à quelqu'un d'autre, puis
Well, you could go on to someone else, and perhaps we could then get another 30 seconds later. Okay.
Please, for 2.5 minutes.
Well, thank you. We heard, earlier that, I cited that the BC First Nations Health Authority, the Canadian Association of Police Chiefs, our Chief Medical Health Officer of British Columbia, Dr. Bonnie Henry, the Chief Coroner of BC, the Expert Task Force on Substance Use, the former Chief Medical Health Officer, Perry Kendall, and Mark Tyndall, who have now been referred to as paid activists, that they're kind of, seemed like they're, by the Conservatives and by some witnesses that they bring, that they're alluding to some sort of conspiracy. Mr. Perrin, what do you think when you hear that all of these experts, or the question was brought earlier that they're not experts in addictions medicine? What do you think when they're deemed as unqualified, or that they wouldn't seek out expert advice when it comes to addictions medicine?
It's a shocking, unethical, and false allegation. I think when you're going to bring aspersions in a setting like this, where you're protected from criminal and civil liability, and you don't give anyone you're making allegations against an opportunity to respond, that's a very dangerous combination. I recently watched a podcast on McCarthyism, and it reminds me of that. You're going to start casting aspersions about people. There's a process and a way in which for the committee to explore any of those concerns they want, and it would, if they want to go down that road, which I don't think is necessary, they should be giving those people a chance to respond. There is a widespread consensus across different groups of people who work on this issue, including among addictions experts, that we need to address the root cause, which is this unregulated drug supply. So you mentioned the BC Coroner Service. I would encourage the committee to not just take that title, but when you look at the report that is the basis for the BC Coroner Service recommendation for regulated alternatives, I haven't even counted them. There's between 12 and 18 listed experts who are all work in this field, including addictions experts and physicians. So it's one thing to say someone disagrees, but to try to suggest that there's something else there is false and misleading and unethical. Ultimately, I would urge the committee, I guess, in closing, to say, please focus on the main concern here. You're studying why this is the leading cause of unnatural death for Canadians, and it's going to continue to go for a long, long, long time unless we begin to address the root causes of it, to do the emergency response now, to build the supports, the holistic supports around housing and addressing childhood trauma and prevention, all that. But we need to deal with the crisis we have urgently.
Do I have time for a very short question, Mr. Chair?
Very short question. Yes, go ahead.
You're the former senior criminal justice policy advisor to Stephen Harper. What would your advice be to Pierre Poilievre and the Conservative Party?
I would just say, please look at this with fresh eyes. This is not an ideological issue, and we need to follow the best available evidence to depoliticize the issue. Why are you in government if it's not for the benefit of Canadians? This has to be about saving lives and not about following the polls or anything else.
Thank you, Mr. Perrin. Next, Mr. Doherty, please, for 5 minutes.
Thank you. Thank you, Mr. Chair. Mr. Perrin, you don't have a medical degree, that's correct?
I already answered your question about that. Of course not. I'm a law professor. So
are you an addiction specialist?
No, I'm a law professor.
Okay. So really the only...
I interviewed those people for my research, though.
Okay. So really the only... you talked about having Canadians on appear before our committee that have lived experience. I couldn't agree with you more. I think that we get much more benefit from that than having a pissed off ex-staffer basically defame his ex-party and potential leader, the next Prime Minister of Canada, at every intervention. Dr. Nosek, you have provided with. I really truly appreciate the testimony that you have given us. over the last little bit. You've offered a lot of insight, as has many of our witnesses throughout this study. It's quite frustrating when you have somebody that comes on and very clearly it's a very partisan attack. When I think for the most part, when we're having these discussions at committee, we have all really tried to do our very best to understand this. It is a very complex issue. And Mr. Perrin, you mentioned in previous remarks that the Conservatives, including our leader, have been spreading lies and misinformation, including that safe supply is what's killing everyone. No one is saying that. What we are saying very clearly on record is that so-called safe supply is an unsafe and irresponsible policy, and that it's making the crisis worse. We cannot.
Your leader said that.
You cannot.
Your leader said safe supply is killing people.
Again, Mr. Perrin, it's my time, not yours. The challenge that we have is that we are perpetuating addiction without getting people either into detox or into treatment, so that recovery and that we can bring people home. I know from what I'm talking about, as I've shared very publicly, the battle that our family has had with my brother's addiction and others within our family's addiction or life and their addictions. I noted that one of our colleagues had mentioned that or maybe it was in your testimony, that we haven't even bothered attending. Just because it's not public doesn't mean that we haven't gone to these sites by ourselves. I don't do things just for social media likes and what have you. I go about doing my own business and visiting these sites on my own. Thank you very much. Mr. Summers, thank you so much for sharing your story today. I appreciate the work that you are in and that you're going through. Long-term recovery. Recovery takes many, many steps, and I do want to ask again, if you feel that there's more information that perhaps you have not had the chance to share with this committee, or documents that you feel that we could benefit from, can you please either mention them today and then send them to us if at all possible? Mr. Summers, is there any, for final remarks, any further comments that you have?
Thank you. I'll add one. It's a growing reading list. But the UK commitment to a recovery-oriented system of care. So a recovery-oriented system of care is the most frequently used framework that governments around the world are using in order to fully integrate all government activities toward a common goal of preventing addictions, as well as actually other mental illnesses, intervening early and promoting recovery. And it runs the gamut from interdiction and international relationships to domestic activities that cut across a broad swath. We haven't yet mentioned the role of, for example, employment, and the fact that 60% of the people who are experiencing poisoning in Canada were unemployed, and they're mostly young people. Employment is powerfully related as a protection against the risk of addiction, and also as a component of promoting recovery. A related observation is that not only are poisoning deaths the leading cause of death among youth in BC, about 60% of the kids we're losing were in government care. So what I'm trying to get at is this is a very skewed, high-risk population. I am not spreading false, misleading, and unethical testimony. I resent the remark. I don't even know why someone would think to say that in this setting. We have actionable steps that we must take that involves our psychology and our social interactions. I'm summarizing that with the phrase social reintegration. We ignore social reintegration at our peril, and now are piling on with additional pharmaceuticals that are making things net worse.
Thank you.
So I'll gladly forward those documents.
Thank you, Dr. Summers. Dr. Hanley, please, for 5 minutes.
First of all, for Dr. Summers. Dr. Summers, do you have a medical degree?
I'm a clinical psychologist.
I
don't have a medical degree.
Thanks. Do you have a law degree?
No, fortunately.
Okay. I just want to say I find it deeply disturbing, Dr. Summers, that you're making serious allegations based purely on speculation about public health officials in BC profiting
I'm
from the
reporting
overdose
facts that
crisis.
have been publicly reported.
When those same
Reporting
people have
facts.
literally dedicated their lives to some of our most vulnerable and voiceless citizens. And I know why Dr. Perry Kendall and Dr. Schechter started Fair Price Farmer. It was an attempt to address a need that was not otherwise being addressed. In addition, Dr. Kendall is one of Canada's great leaders in public health. I've been fortunate to be a former colleague of his. And I'm sure he would be happy to come to committee to explain a Fair Price Farmer. I want to just go back to you, Mr. Perrin. Mr. Perrin, would you describe yourself as a pissed-off partisan ex-staffer?
No.
Perhaps you'd like to clear the record on that one.
Yeah, I appreciate that. Yeah, no, my concern on this issue has grown out of the research that I've done the last several years, and spending most of that time, particularly in my last project, talking to people whose lives have been devastatingly impacted by the criminal justice system, by addictions, by substance use. And all of us have people in our own lives who have experienced this. When I wrote this book, Overdose, I didn't know anyone who'd passed away from unregulated drugs. Now I do. And the very grave concern I have, and the strong comments I've made today, are because I see a lack of adequate response, and it is killing people. And that is what motivates me. And I will continue to speak truth on that, and I'm going to continue to call it out, and I will call it out whatever the political party is. And so if I'm pissed off, that's the only part. I guess I'm pissed off. I am. I think if any of us were not, that we continue to see people dying in the numbers they are, and we really cared about that, that should enrage us. But it has to motivate us to action.
Excuse me, Professor Perrin. Avez-vous
Yes.
l'appel à règlement, Monsieur Thériault?
Mr. Thériault, do you have a point of order? I didn't want to interrupt the witness. This is very interesting, but since I have, you owe me at least 30 seconds. I'm sorry, I didn't hear what you said. I said that you owe me 30 seconds. Don't forget, please. That was for Ms. Jutras? Well, I have other questions, too. There's other witnesses. I could ask questions for another 30 seconds. I had time that was mine for the answer. I'm sorry. I apologize to Mr. Perrin. I didn't mean to interrupt him.
Professor Perrin, please go ahead.
That was my answer. Thank you.
Thank you, and I hope I can have my minute back that I lost as well. I just wanted to state again for the record, back to the leader of the opposition, the member for Carleton, who does say government-funded safe supply programs are leading to more opioid deaths. But I want to leave that for my last minute or so, Mr. Perrin, back to you. So you're bringing us back to. Let's bring this back to federal government recommendations from the committee, immediate actions, and maybe top 3 immediate actions that we could advocate for putting in place where perhaps we're not doing enough at federal level.
I think we need to mainstream what I would describe as safe places for people to use drugs. Calgary Mayor Naheed Nenshi said that his concern when he left the mayoral office is they only had one supervised consumption site. So where you have one, that's where you get a concentration of people. That's where you get concerns. These need to be more mainstreamed. So that's the first thing. We should look at the mainstreaming of supervised consumption sites as a basic health response. Secondly, we need to look at regulated substances, not just unique programs, but we need to completely look at how do we replace this toxic supply, and we should be looking at a number of alternatives that respond to concerns about things like diversion, and look at different models that could work and be willing to do that. The third thing is I think we need to have some national standards on what recovery and treatment means, and I mentioned 5 specific things: evidence-based, rapid access, publicly funded, regulated, and finally trauma-informed and culturally appropriate.
Do I have more?
Yeah, you have about another 40 seconds.
Oh, that's okay. That's great. I wonder maybe I can bring you back to BC and the adjustment of the decriminalization approach, and I again sense that there's a confounding of public disorder or public nuisance with decriminalization. I wonder if you could just comment, I guess briefly, but on the progress so far that you've seen with the approach from BC and what you would hope to see from now on.
Well, in terms of British Columbia, one of the things that the province has done really well is creating a large number, more than anywhere in Canada, of safe places for people to use at the provincial level. And that's when you've had a supportive provincial government. When we don't have that in provinces like Alberta and Ontario, then funding is the chokehold against supervised consumption sites. So even though they get approved, if they're not funded, they are not going to be effective. So that is a huge issue in terms of the federal role. In terms of BC, I think it has been a real mistake to recriminalize the possession. It is in fact not the public drug use that has been criminalized, as was announced. It's the possession. That means someone walking to a supervised consumption site is liable to arrest now. And that was not the case prior to this rollback. And so we need some really serious thought about what needs to be criminal, what can be administrative, and we need to go back and revisit that.
Colleagues, we had some technical difficulties that resulted in Mr. Theriault losing a question. The witness has not been able to return, but in the interest of fairness, before we close the meeting, I think Mr. Theriault should have his question back. So the last question, a brief question and a brief answer. Mr. Theriault, s'il vous plaît.
Oui, je vais m'adresser.
Yes, thank you, Mr. Chairman. That's very kind. I have a question for Mr. Summers. I look at my notes here. I see a lot of denunciation, but I didn't see any solution being proposed. Could you do the same as Mr. Perrin and tell me the three main solutions you advocate in order to solve this problem of organized crime-led toxic drugs that kill?
I would make the premise about people rather than about drugs. If we focus on individuals, on human beings, then we have people who are greatly at risk, who are socially isolated, struggling mentally, are unemployed, and on average are young people. So there are voluntary things that we can do immediately, and that would be recovery-oriented housing. I'm not going to be able to break this down. Demonstrated around the world and in 5 regions of Canada through randomized trials as highly effective.
Est-ce que ce serait des logements?
Would that be supervised housing? Because we're talking about drug addicts here.
I'm talking about people with addictions as well.
Thank you.
The people we're losing are unemployed people who are disproportionately living rough and are socially isolated. As I said earlier, more than half of the young people dying in BC were children in care. There is a profound link to social isolation and meaning in life. So there are voluntary interventions, such as recovery-oriented housing. You'll have to, I'm not defining it. For people who are encountering the criminal justice system, drug treatment courts and other specialized courts, when properly resourced, are extremely effective. The third point I'll mention is prevention. We must do a far more effective job preventing risk associated with substance use in the first place. So those would be my 3
Thank you.
top priorities.
Est-ce
que la prévention
I said one question, not a complete turn.
Thank you to everyone for being here with us.